I think from my perspective or understanding, this proliferation of programs, if you will, had major impacts, actually. Until this time, the Title V Children with Special Health Care Needs programs were essentially the only game in town. All the way from the 1935, 1930s era, when the legislation was passed for this program and with a special emphasis on crippled children at the time. So they were the only game in town, which meant that they could set the standards for care. They could have sort of direct connection with the population that was being served and so forth. With this proliferation and Medicaid being the, as it is today, the big gorilla in the room, the elephant in the room, whatever, that made a major change. So there was concern, for example, with Medicaid that while there were more resources, which was terrific, more resources available for serving the population, that program was independent of Title V and the Title V arrangements that they had with specialists, pediatric specialists around the state to provide care to these kids. And just anyone could, basically be a provider. So there was real concern right from the start that, we didn't want our poorest of the disabled population group to get substandard care. So there was a lot of thinking about how do we, as Title V programs, make sure that this population gets the same kind of care as they've always been getting when it all sort of came through our doors, if you will. But, we don't have control over that because it's being financed by a different governmental entity. And I recall my boss at the time, and I was working in a special needs program in the state, saying, he who pays the piper plays the tune. And so there was a lot of questioning about roles and how to, sort of make sure that the population was protected in the way that they needed to be. I think the other aspect of that was with Medicaid and the way that the financing system was set up, Title V had to become much more sophisticated about sort of financing schemes. It wasn't that they just got a grant and provided services for the population, but they had to make arrangements with Medicaid for some of the services that they had heretofore provided or that they arranged with specialty clinics and so forth, were reimbursed to their programs. And that was just a whole set of activities they hadn't been used to. So, it was this good news, bad news kind of thing. EPSDT, similarly, there was delight when that program was envisioned, and it was actually envisioned originally to be in the Title V program because it so much mirrored the diagnostic and evaluation services that the Title V special needs had been providing. But over time it got for some political reasons that I don't recall, or maybe I never knew about it. But in any case, when it became part of Medicaid, sort of working that all out with the Medicaid financing accountants, if you will, as well as the provider system was a big deal. The proliferation of programs, large among that also was, as everyone knows now, was the Education for All Handicapped Act, and the planning grants started, 10 years before that. And that program sort of influenced the program in a different way in that health services were built into the educational services as that program emerged in the planning grants and in the final legislation. And so that really meant another sort of set of activities to redefine what Title V had been vis-a-vis the population in evaluation and setting care plans and so forth, when there was responsibilities put into the education sector. So they had to reach beyond the medical sector, which had really been where Title V had done their work, and learn about education in a governmental system sense, and also sort of the players and how to work this through. It was all very new. I guess much like working through with the Affordable Care Act today. There were big, big changes, and there was a real need to redefine what the programs were doing. The LEND programs, which emerged during that time, which were related to the attention to mental retardation, and that also sort of caused welcome change in terms of more resources and more reaching out within the medical community to get more interest and more training in pediatric subspecialties and in neurodevelopmental disabilities, which was the large part of the population served by the special needs programs. But again, and these were many of the same players in this instance, as opposed to in special ed or in Medicaid, where these were different actors, if you will. But many of the same players that Title V had been used to working with. They worked with the programs, but working out the new logistics of operationalizing the lens and their relationship to the Title V program. So there was a lot of work to be done. In a nutshell, it was a set of much more rich resources, if you will, for the population, to have the population cared for. But on the other hand, the level of complexity of the work of the programs really expanded tremendously and became much more focused on operations, on administrative matters and so forth, which had been pretty clear and clean cut. And so one might also say that the set of skills that were needed in the programs also were influenced by that as well. So not just having PTs and OTs and physicians and nutritionists that were looking at quality of care issues, but also needing to have people who had some other expertise in policy, in intergovernmental affairs, in financing, and so forth.